Hi guys, this week's we'll be talking about a number of GI topics. So to start off with, we'll talk about laxatives and the treatment of constipation. Talk about a couple of common problems, but constipation can really occur from a variety of causes. Usually in patients it's temporary, but sometimes you can have chronic, and we'll talk about both. There's a lot of treatment options. Most of them are over the counter. There's a couple of prescription-only things that we'll mention too. And most of them, the idea is that they act locally within the GI tract itself and don't cause any systemic side effects, which is helpful in most cases. And for most people with constipation, the etiology is idiopathic, but something is slowing the colon transit time down. And sometimes you can pin down the source, and sometimes it's difficult to figure out what's causing it. So here's some chronic constipation causes. So if you do have a patient you work with that has chronic constipation, they may be associated with some of these different disease states and disorders. Here are some drugs that generally are associated with causing constipation. So probably the biggest ones I think about are anticholinergic medications and opiate analgesics. So those are probably going to be the two common classes that you're going to see used in regular practice that will cause constipation. Definitely, especially if you have somebody on opioids, like if they're post C-section or maybe post even if it's a post-vaginal delivery where there's a more than average amount of pain involved, something like that, or any patient you see with pain, this is just going to be something that comes hand in hand with using an opioid medication. You're going to get constipated. It's really important, I think, to stay on top of the constipation so that you aren't waiting until your patient hasn't had a bowel movement in several days to prescribe something or to recommend something. You should be proactively recommending something. Okay, some education about just what to do and how to avoid constipation without getting into the drugs yet. So always advise to defecate after a meal. So normally your body has postprandial increases in colonic motility and also usually highest in the morning. So basically it's directing people to take advantage of their body's normal signs and cues to defecate. And if people are holding their bowels, then it can create more of a compounded problem. Changing your diet is also something too. We'll talk about some products that you can supplement fiber with, but dietary fiber intake, so fruits and vegetables, can help. Fluids are a big part of this too, and I put a bunch of foods down there that are kind of more associated with helping with constipation too. So fiber is something that can supplement. So if somebody's dietary intake isn't adequate, and you don't think that they're going to really be changing that, you can supplement this pretty easily. So there's a number of different products in the market. They're all essentially the same thing. They're insoluble solute, you can think about it, that's increasing the bulk within the GI tract. And so what happens is you can get water that pulls into the GI tract to help soften stool and help push stool through, and also with the formation of more of a bulk of these insoluble products in the GI tract is going to help the colon and the GI tract stimulate movement, and will help move things through a little bit better. So fiber is a natural part of our diet, and there's plenty of fiber in diet, but some people may have more fiber-rich diets, some people may have more fiber lacking diets, and those are the people that would benefit from this type of a product. If you do take a lot of it, you can get gas and stomach cramping, so it's best to have people start with a small amount once a day and see how that works. And there's a number of products again on the market. I've listed the common brand names here, but they not only come in powder mixes that you'd mix with a liquid, that's pretty common, but you'll also see a lot of different tablets, wafers. There's products made into granola bars and all kinds of stuff like that. So whatever works for people. But fiber is kind of fiber. It's insoluble material that's forming a bulk product in the GI tract that's going to help things move through and help water get pulled into the GI tract a little bit more efficiently. Surfactants, or what we call stool softeners, there's really there really shouldn't be a plural on this because there's really only one medication in this class. It's docusate, and it's probably the most common over-the-counter constipation relief that people take. It doesn't have a great amount of efficacy associated with it, but we'll talk about it just because of how common it is, and it's pretty benign as well, so not really going to hurt somebody to give it a shot. What it's going to do is lower the surface tension of the stool itself, allowing water to more easily enter the stool, meaning that the stool, it's going to loosen and it's going to be softer. So it is a stool softener for that. That's why it's called that. There's really no side effect to taking Docusate. However, the efficacy is quite limited, but people still take this a lot. It's inferior to psyllium in one review that I found, but there's not a lot of evidence either for or against it. I think the majority of people could try it, and if it doesn't work, move on to the next class. Now, if you combine it with a stimulant laxative, it does make a little bit more sense because you can soften the stool to help get it out of the GI tract, and at the same time give some sort of a stimulant agent to help push things out, which can be a synergistic approach to constipation. Osmotic agents are kind of similar to fiber in a sense. However, it's a bit more of a potent effect. And what you get is basically the same type of a concept. So what you're looking at is some sort of insoluble thing that gets into the intestine and pushes out water. And that's in some cases. Now, there's other cases where osmotic things can work by shifting concentration gradients of electrolytes, which we'll talk about in a second. But the most common product is going to be a polyethylene glycol. And again, it's just an insoluble polymer chain that you ingest, and it causes intestinal water secretion to increase. So problem is with this is you can overdo it a little bit and can end up losing electrolytes, and that's generally a problem with any type of agent that's going to cause changes in intestinal water content. You can end up decreasing your ability to absorb electrolytes or changing the concentration of your electrolytes in your body. But in most cases, it's pretty safe. If you're going to do a full colonoscopy prep on somebody, like this product here called Go Lightly, it's basically polyethylene glycol, but they replace it with some electrolytes so that you aren't getting that deficiency like you might get in other cases. There's also some synthetic disaccharides that work pretty similarly. So it's again insoluble sugar that gets into, or starch that gets into the GI tract and pulls water through it. These products are generally not used, like sorbitol and lactulose, for this reason. Lactulose is used a lot for high ammonia levels in alcoholic patients because it prevents, it has a different mechanism of action that I'm not going to go into right now. But sorbitol is a product that was used a while ago. Oops, get rid of that. And doesn't really get used all that much anymore just because it does work a little bit too well in the sense that you get a lot of diarrhea. People generally feel pretty bad on these, a lot of bloating, severe abdominal pain. They're inexpensive, but polyethylene glycol products are always going to be preferred just because they don't have as severe of side effects and not as severe of effects in general. Then there's different types of saline laxatives. So magnesium citrate is probably a pretty common one that's bought over the counter. Milk of magnesia has the same thing. Basically, these are poorly absorbed magnesium formulations. And again, none of these medications have a lot of side effects unless you overdo it. But you can get some magnesium absorption from these products, even though the formulation they come in is pretty poorly absorbed. You're consuming enough of it that it can build up over time. In that case, you have to watch your patient's renal function. People with poor kidney function will accumulate magnesium in these cases. This is a little joke I have. If you guys want to entertain yourselves, check out this review. This was floating around the internet a couple of years ago, so some of you have probably seen this. But these are some sugar-free, quote-unquote, Haribo gummy bears that are made with a product called Lycosin, which is a sugar alcohol, and essentially is the same thing as like a sorbitol, synthetic disaccharide that causes excessive diarrhea, according to a lot of the people on the reviews. So if you're interested in entertaining yourself, check that out. It's kind of funny. And some of the reviewers are pretty descriptive in their side effects that happen. All right, stimulant laxatives. So after electrolyte transport by intestinal mucosa will get altered by these products. So two products here, Senna and Bisacodyl. Bisacodyl comes as a tablet and a suppository. It's very potent, and it's not prescription only. That's wrong, but there are some strengths of it that are prescription only. And the suppository is really fast acting, and it's probably the most potent laxative we have on the market. Then there's Senna. Senna's not quite as potent. It's still effective. It's oral only. This is probably the most popular choice for like opioid-induced constipation if you're looking at short-term opioid use, like post-surgery or for some kind of an injury. And it's usually combined with docusate. So the products that are Senna S or Senna Plus are with the stool softener. And remember we talked about that synergistic approach that way. This next slide is really just to show you that nothing works quickly. Any oral laxative, you're looking at least probably a 12-hour time frame before you're going to see anything start. The one exception is magnesium sulfate. So this actually does work pretty quickly orally, and it's probably by far the fastest one. Or magnesium citrate, I'm sorry, we don't really use magnesium sulfate anymore. Magnesium citrate would be like that over-the-counter glass bottle that you might see at Walgreens or something. It does work quite quickly. Otherwise, you have to look at suppositories. So you're looking at bisacodyl suppositories. See the suppository, 15 to 60 minutes. So the moral of the story is if you really want a fast-acting laxative, you're going to be looking at a rectal administration, not oral administration. A couple of new products for chronic idiopathic constipation, Linzess and Amitiza, excuse me. And what Linzess does, it's a minimally absorbed peptide agonist, and so it stimulates intestinal fluid secretion in transit. And lubiprostone is a locally acting chloride channel activator, and you get an increase of this chloride-rich intestinal fluid secretion, which helps move things along. They're both dosed once daily. They have minimal side effects, with the exception of Amitiza having a bit of nausea associated with it. For severe constipation, suppositories, enemas are always going to be faster. So for an impacted colon or something more problematic, bisacodyl suppositories, sodium phosphate enema or Fleet's enema can be used for this too. That's another product that's pretty popular. There's a lot of Fleet's brands on the market, but the sodium phosphate is a standard among those brands. It's kind of the original Fleet's, and it does work fairly quickly. A couple other options I'm not really going to spend any time on. Basically, it'd be situational use. If you had somebody with muscle dysfunction, you could actually give Botox or botulinum toxin injections locally, and you can maybe paralyze or you prevent the muscle from spasming that way, and it can help with some symptoms too, like for a person with spinal cord injury or something, but it'd be a really unusual situation to do that. So, in summary, you're going to address your underlying problem. Your strategy is going to focus on diet, hydration, and fiber supplementation, whether that be dietary or a supplemental fiber. Osmotic and stimulant laxatives, plus or minus a surfactant. I'm not a big fan of just giving somebody a surfactant and expecting it to work, but in some cases it might. You have to consider what the cause is too. For like opioid-induced constipation, just giving somebody a stool softener is not going to do anything because opioids slow GI motility, and what we need to do is speed that up again or help things move through. So you can soften the stool. It's still not going to go anywhere if they're taking opioids. And then chronic item-specific cause, the newer chronic agents, so the lubiprostone and Linzess, those ones could be tried. And then, of course, there's other specific things for more complicated cases. But that's probably a little bit outside of the scope of practice and would be more of a GI specialty thing anyway, so we won't go into too many details on those. All right, moving on to antidiarrheal. So chronic versus acute, infectious in nature, medication-induced, illness-related. There's a lot of different things we want to assess, and depending on what's going on, we're going to treat things quite differently. So oral rehydration is going to be really important. You're at a high risk for dehydration and electrolyte disturbances. Salt, water, sugar, good solutions to replenish, because you want to replenish some of those lost electrolytes. You also want to replenish some calories. If your patient hasn't been eating anything in a while, a little bit of sugar can help with that. In severe cases, you can have IV hydration done too, so you could admit somebody to the hospital or whatever for that. And then antibiotic therapy, because so many cases are infectious disease and oriented. Usually we're going to do some sort of stool culture, specifically if somebody meets certain criteria. And usually if somebody has severe enough diarrhea, we want to test for Clostridium difficile antigen, make sure they don't have C. diff. If they do, we need to treat them fast because we don't want them spreading C. diff to other people. C. diff can have devastating consequences in certain patient populations, so we do want to treat it very like it's an important priority. A lot of bacterial infections are self-limiting. Some severe cases, fluoroquinolones and macrolides can be used empirically. But there are some problems with this, and we'll talk about those in a second. Viral infections, which you can't really tell between a viral and bacterial infection. However, usually viral infections have a bit faster of an onset and they're more short-lived. So like norovirus, for example, really fast onset. It's usually only lasts a day, maybe less or maybe a little bit more. But a bacterial infection is going to take a little bit more time, especially like C. diff or like salmonella poisoning or something like that. Diet, if somebody is tolerating food, easy, soft, bland, digestible foods like the brat diet, so bananas, rice, apples, applesauce and toast. You can gradually reintroduce foods, basically staying away from really greasy food and really spicy food. For symptomatic therapy, you have a couple options. And most of these are opioid-related products. So loperamide, Lomotil, and opium tincture are all products that exist. Imodium or loperamide is the over-the-counter one. It's an opioid receptor antagonist, and it has no systemic side effects. It doesn't really get absorbed systemically at all, so it works locally in the GI tract, which is why it's over-the-counter. And it's probably the most effective item out there that's easiest to get for people. There's another product called Lomotil, which is kind of the same but has some systemic opioid effects. And then you have opium tincture, which is more of a severe case, chronic diarrhea type situation, which is pretty unusual to actually see it used, but it is actually opium that's been put into kind of a liquid suspension form. The problem with using these is the fluids in the GI tract can pool because you're slowing down motility, which can help with symptoms but can cause problems. So you should have oral fluid intake that's pretty aggressive. So that's always a big cornerstone of treating this, not only to replace what you're losing in the diarrhea, but make sure things keep moving through so things aren't pooling. And you can have really big problems if you give these medications in the setting of infectious disease. So fever and dysentery would be the two keys that you wouldn't want to prescribe something like this. So that's why we do a stool culture on a lot of patients who have maybe something leaning towards an infectious disease presentation. We want to make sure that we're getting them treatment, but we also don't want to pool up bacteria producing toxins in their GI tract when we could be treating them otherwise. So in a lot of cases, we're going to either give them antibiotics or we're just going to let them self-limit. The disease is self-limiting enough where they kind of have to tough it out for a little bit. But it's important not to have them slow down their GI tract when they have a bacteria in there that could pool and make things much worse potentially. Pepto Bismol is something that has a number of different kind of roles, and a lot of them are questionable, but we can use it's bismuth subsolate, so it doesn't have as much evidence associated with its efficacy compared to like the opioid medications that we just talked about. It does have anti-secretory and antimicrobial activity, so you might get some slowing down of the GI tract because less things are getting secreted into it from like less fluids, so it might not move quite as quickly through it. It does have a bit of an antimicrobial effect locally too, so people take it for prophylaxis for travelers' diarrhea. There's some studies that show if you take it with every meal consistently, it does actually prevent in some cases. However, most people can't adhere to that type of a schedule, and it also causes grayish-black stools. It can cause constipation, darkening of the tongue, some odd side effects. So for the most part, we don't use it. And it is contraindicated in pregnancy in children due to that salicylate moiety, meaning that it's similarly related to aspirin, so we don't use it in kids or pregnant women. And then probiotics, figured I'd mention these. So I had a friend who once said, she's a pharmacist actually, and she was like, if I'm on an antibiotic, I should be on a probiotic, right? It's kind of her mantra when she was taking an antibiotic for something. And the question is this good wisdom, or is it just kind of something we should, is it just maybe an old wives' tale? Well, probiotics are probably effective for a variety of mild diarrheal-related illnesses, and I say mild, put the emphasis on that. There's not really any good evidence to support that they make any difference in severe cases. They don't seem to make any difference in preventing things like C. diff or treating things like C. diff. So unfortunately, while they probably have some benefits to promoting a healthy GI tract and replacing maybe some of the natural flora there if it's getting lost, they probably aren't going to have like a really big impact. So is it fine for patients to take them? Absolutely. Should they expect, their diarrhea to go away the second they start taking it? No, it's probably not going to work like that, but it can help restore their GI flora theoretically. What I would tell people is that look at the person's diet to begin with. If somebody consumes like yogurt on a daily basis, they probably don't need to spend extra money on a product like Culturelle or some sort of probiotic because they are kind of expensive. And while, again, it's not going to hurt them, it's just that why do they need to take it when they're getting it from a dietary source? Or maybe somebody's a big kombucha nut and they drink a ton of it. Well, they don't need to take Culturelle on top of that. So there's just some things to think about when you think about probiotics. But generally speaking, they're not going to be harmful. The one problem I will mention with probiotics potentially is that around immunocompromised patients, there has been associations with infections caused by things like lactobacillus and Saccharomyces and people who are severely immunocompromised. So it is something that we actually banned from our hospital, kind of. We still allow it in certain cases, but we took it off our formulary and we don't allow it to be ordered anymore unless somebody puts up a pretty big fight about wanting their probiotics. And the reason is because, again, there's not a lot of evidence to support that it really helps anything, and that ultimately if somebody's off their probiotic for a week or two while they're in the hospital, it's not the end of the world. And the risk of causing a severe infection in an immunocompromised patient outweighs the benefit of outweighs any perceived benefit these would have. So you might run into that type of a thing too. But again, for the average person at home with no real issues going on, wants to try a probiotic because they're having some diarrhea, it's likely not going to hurt anything. Quickly talking about prokinetic agents, gastroparesis is delayed gastric emptying without some sort of specific mechanical obstruction. And you can control it dietary, so people who have diabetes are at risk for this, and you can do it by making sure their diabetes is in control. Dehydration can cause this too, so improving that. And there are a couple of pharmacologic agents we can try. Metoclopramide we're going to talk about a little bit more in a second here. We're going to talk about antiemetics, and so I'm not going to go into the mechanism because we'll get to it in a minute. But it is a medication that is a good antiemetic, but it also has good gastric motility effects. So it's a first-line gastroparesis agent. It has very few side effects, and I'll go through these side effects in a minute here, so don't worry about them right now. Macrolide antibiotics also work. So erythromycin, while we don't really use this for infectious disease anymore because it's either resistant or it causes so many GI-related side effects that people don't tolerate it all that well, it does help move the GI tract along. It agonizes a specific peptide hormone called motilin, which, funny enough, is a motility-related enzyme that helps move or motility-related peptide that helps move the GI tract along. It stimulates fundic contractility. You have to do it 4 times a day. Usually liquids preferred because it helps it get into the GI tract and coat and have a better effect than if you gave a tablet. And it's also dosed IV as well, so you could give it to somebody in a more severe situation. Azithromycin as a macrolide could be used too, but generally isn't. We stick to erythromycin just because erythromycin doesn't have as many roles in actual infectious disease. Azithromycin still has some role to play, so we don't want to breed resistance when we don't have to, and that's of course one of the big issues here. Also, people get tachyphylaxis with this, where it's working fine, and then all of a sudden it just stops working. We don't really know why, and people can tend to have kind of nasty side effects: GI toxicity, ototoxicity, QTc prolongation too. So that's a lot of reasons why we like metoclopramide more than the macrolide antibiotics. And we'll get to some of this stuff in this next lecture, so don't worry about it right now. And generally just talking about pregnancy considerations. So hormonal changes do affect the small bowel, and it will affect colonic motility. So this is something you're going to see in your pregnant patient population. So constipation, generally speaking, none of the products we use to treat constipation are systemically absorbed, so they're fine. You might see people use things like castor oil and excessive mineral oil. These things can be problematic. So castor oil, you guys probably have heard about this, or maybe Katrina's talked about this already, but and I don't know the evidence on this. I just know that my wife we just had a baby, our second baby, and she went over by about 8 days, and people were like, oh, try castor oil. And everything I read about trying castor oil made it sound like people ended up just miserable and didn't actually end up going into labor. So I said, don't do that. But so castor oil is associated with premature labor in some cases, and while the evidence, I don't know exactly what it is, but I assume it's a bit mixed. The idea of putting somebody into labor early when you don't want to would be a problem, so we want to avoid that altogether in case that does happen. Mineral oil can do a similar thing too. So mineral oil in small amounts is probably fine. Rarely people actually use mineral oil, I don't think, but it is an option that I didn't talk about, but basically it's a lubricant that would help things move through the colon a little bit more smoothly. An excessive use of this could cause not only vitamin malabsorption, but you can also get issues that are similar to the castor oil issues. Diarrhea is really just supportive care. There's not a lot of systemic items that you can really use. The studies on the opioids, like loperamide, animal models have shown no teratogenicity. However, there's been some human studies that are conflicting. It's likely safe, but for the most part, it's avoided. So usually it's just supportive care. In most cases of diarrhea are probably self-limiting, and you want to make sure you're supplementing with adequate fluids and whatnot. But there's not a lot you can do, especially for if it's a viral diarrheal episode, which is probably going to be the most common thing you're going to see. You really just have to tough it out. Again, hydration status, diet, primary areas of focus in pregnancy, just like you would with any patient. Okay, antiemetics. Antiemetics are used for a ton of different conditions that can cause nausea and vomiting. So we aren't really going to go into the specifics on what you use when. Some of them are more specific to maybe chemotherapy induced, some might be more general, but a lot of them cross over. So we can talk about them sort of in a general group of medications that work for preventing nausea and vomiting or treating active nausea and vomiting. So our basic mechanisms, we can look at anticholinergic drugs, muscarinic receptor antagonists, dopamine antagonists, histamine antagonists, and serotonin medications too that work in the GI tract locally. There's a chemotherapy use only one called neurokinin 1 substance P that's this drug called aprepitant. Don't worry about that. And there's not a lot of actually good evidence comparing these drugs. There's some that compare classes and agents, but usually they find that they're non-inferior to each other, so we don't really know specifically. And some of the evidence is even more conflicting than that. So most of the time people are using this based on their own personal experience or anecdotal experience that they might have been on. They might have trained with somebody who really preferred one agent over another. But usually there's kind of a logical approach to this that makes it so there's not actually that many options available. But we'll talk about the ones that we have. Anticholinergics, so scopolamine is really the only pure anticholinergic. It doesn't really work to treat active nausea. However, it is a motion sickness prophylactic agent. It's a transdermal patch you put behind your ear every 72 hours, and you can put it on about 2 to 4 hours prior to need. So if you're going on a cruise, put that on 4 hours before you're going to get on the boat, and then it should have a good effect after that. It is anticholinergic. You do get dry mouth, drowsiness, and vision disturbances. However, you don't get the GI side effects or urinary side effects like urinary retention and constipation that you would from an oral medication. Just because it doesn't tend to get into the GI tract very much, it absorbs transdermally and stays within the blood circulation. Doesn't really affect the GI tract for most people. Antihistamines can work pretty well. So Benadryl or diphenhydramine is a nice one to keep in your arsenal. It works IV, IMPO. Scopolamine is kind of similar in the sense that they're both pretty anticholinergic medications. So you could use this for motion sickness too. However, it does seem to work a little bit better for active nausea, I should say, than scopolamine would. And it's pretty benign for the most part. I mean, you could get a little bit sleepy on it. So I wouldn't give it to somebody right before they have to go to work or something. But if you're trying to trial something, it's a good one to to try and see if it has any effect on the person. And generally speaking, diphenhydramine is okay to use in pregnancy. So that would be a good option for a pregnant patient. Promethazine is another antihistamine and actually goes into our dopamine receptor antagonist category too. It's got both activities, so it does work decently. Phenergan's the brand name of promethazine. Promethazine also comes with a or came with a cough syrup with codeine added to it, but it's been rampantly abused. Very popular in the hip hop community. Here's some Instagram of some rapper basically blatantly abusing the drug. The company that makes this is Actavis, and they were, or Actavis, I think is how you say their name, but they pulled it off the market because they felt like most people were just abusing it. It doesn't really have much of a role. Promethazine itself is an effective drug. You don't really need the codeine to be added to it, and it was just causing potential for abuse. So again, this is primarily an antihistamine. However, you do get dopamine activity, which we're going to talk about in a second. And it comes, I think, as an IV product. So the difference is, between some of these other ones, and I guess we can just move on. This one is safe in pregnancy generally, so that's one to, again, keep in the back of your mind. But if we compare this to the other ones in this slide, so prochlorperazine or compazine is another really popular antiemetic, and they're basically in the same class because they're both dopamine receptor antagonists, whereas prochlorperazine doesn't have any real antihistaminic property to it, whereas promethazine does. That's the big difference between the two, but they're kind of interchangeable otherwise. And so where promethazine has a bit better data in pregnancy makes it maybe more preferred in that population, whereas prochlorperazine is generally preferred in pretty much everyone else. It's thought to work pretty well. It's got pretty limited clinical data, just like all these medications. All these medications have been around for a decent amount of time, so as far as evidence goes, we just kind of assume they work, and they've been grandfathered in more or less. There are some studies, but they aren't really big or robust. Just like any good medication, it comes IV, IM, PO. So that's nice for anything treating nausea and vomiting. You want IV and IM routes to make sure you can give it in ways that aren't oral if somebody's not tolerating oral intake. And when you compare this directly to promethazine, one of the differences you might see is the infusion. So with IM or IV dosing, you can give compazine pretty much push. Promethazine can be really hard on the vasculature, and you have to dilute it out substantially before you give it, and you have to give it really slowly. So if you're going to give something IV, prochlorperazine is a lot more easy for a nurse to give and administer than promethazine is. I put chlorpromazine on here, or Thorazine. It's an older antipsychotic. And I should probably talk about these medications a little bit first. So dopamine receptor antagonists, within the chemo trigger zone, chemoreceptive trigger zone within the brain, you end up with a number of different receptor subtypes, and dopamine receptors are part of that. And by antagonizing them, you can prevent the body's natural reflex to nausea and vomiting. To like the foreign whatever's causing the reflex to induce nausea and vomiting, I should say. And these are historically developed as antipsychotics. So there's a lot of schizophrenia treatment that revolves around dopamine. And in this case, we have some medications that, like chlorpromazine, that actually still is used sometimes as an antipsychotic, whereas prochlorperazine really isn't. However, all medications that work on antagonizing dopamine can cause these side effects that I've listed down here. So EPS stands for extrapyramidal symptoms or syndrome, depending on what you read. But extrapyramidal symptoms are a group of movement disorders. It's kind of like Parkinson's disease manifestations. So you get tremors and movement disorders, dyskinesias, stuff like that. Tardive dyskinesia is a more permanent thing. So EPS usually happens very quickly. So if you gave somebody a shot of compazine and they started having tremors, that's extrapyramidal symptoms. They should go away after a period of time, and you basically just note, oh, this person got EPS with their prochlorperazine. Probably shouldn't repeat it in the future. But it's usually nothing to worry about in the grand scheme of things. It should go away after the drug wears off. Tardive dyskinesia, on the other hand, is permanent, and it's usually associated, it's a movement disorder as well, but it's more associated with facial tics and like weird tongue movements that are involuntary. So people who get TD, that's permanent, and so that's a really rare side effect, but it is something that can happen with any of these dopamine receptor antagonists. Now, you can pre-medicate people with diphenhydramine. However, I'll be very clear on this. If you're giving somebody just compazine or just promethazine, there's no reason to pre-medicate them. The risk for this is super low with those drugs. It does get much higher if you gave Thorazine. Thorazine is really rarely used for nausea and vomiting, so don't worry about it too much. Just know that you can treat, pre-medicate if you need to. A bit more potent, and ones you may want to consider premedicating with diphenhydramine, would be droperidol. The problem with droperidol is that it's not really available anymore. It's been on shortage for several years. There's some sort of a raw materials issue with supplying it, so maybe it'll come back sometime soon, but currently we can't get any. It's an IV-IM product. It's a short-acting version of haloperidol. Haloperidol is a very old classic antipsychotic medication that I've got listed here below. And it got really popular because you could give people really huge doses of droperidol, and it works really quickly to calm them down. Somebody in acute agitation, but it was approved for nausea and vomiting in much lower doses. So it was really a cornerstone of nausea and vomiting treatment. Unfortunately, we don't have access to it anymore. And then haloperidol could be used, but it's a really long-acting version of droperidol. It's gonna sedate somebody heavily. It's just not. I've only used it a couple times in really weird situations for nausea and vomiting. It's unusual. And the same issues with side effects, those extrapyramidal symptoms, and much more so with these medications. So if you're going to give them, you may want to consider, if droperidol comes back on the market and you start using it, think about maybe premedicating with Benadryl, especially if you're going to give a large dose of it. And finally, metoclopramide or Reglan. So we talked about this as gastric motility, but this also comes works as an antiemetic, and that's what it's mostly designed for. It's category B in pregnancy, so out of all the dopamine receptor antagonists, this is the preferred agent to use. Whereas prochlorperazine is like a category C, and the evidence for it's a little bit conflicting. I think it can be used in some cases. Promethazine maybe being a little bit more preferred, but Reglan generally, from what I've seen used, is kind of the preferred agent in pregnant patients. There's a little bit more evidence to support that it's safer. So one thing I'll just say, since this is the last dopamine receptor antagonist we're going to talk about today, is not to mix and match dopamine receptor antagonists. So if you give somebody Reglan, you're done with your dopamine receptor antagonist. You aren't going to give them a dose of Reglan and then say, oh, that didn't work, let's try Compazine. It doesn't work that way. The reason is because while all these drugs have really low risks of movement disorders like EPS, the more you give of them, the higher the risk gets, and the more you combine them, the higher the risk gets. So we always want to be really careful about that, and that's why we want to avoid it. So that's pretty much it with dopamine. And unfortunately, even though metoclopramide's better tolerated in most, from literature point of view, in pregnant patients, it is probably the weakest of the medications, so it may not work quite as well as a drug like prochlorperazine. But again, we don't really have the best studies to support that type of a statement. It's sort of just anecdotal. Second generation, other options. There's a lot of other options out there. Excuse me, I'm sorry, I meant to say there are not a lot of other options out there. There are some, because we lost droperidol due to drug shortages. They've been experimenting, and by they I mean just physicians in general, have been experimenting with other medications. So one of the popular ones that's gaining a little bit of traction is called olanzapine, or Zyprexa is the brand name of that, and it's an antipsychotic. And it does come as an IV or IM formulation. Well, it's an IM formulation, but people give it IV even though they aren't technically approved for that. They do it anyway, whatever. But it does give a kind of an additional tool in the arsenal for how to treat nausea and vomiting, but it'd be a really unusual case where you'd actually use that. All right, so serotonin receptor antagonists is the other big group of drugs. So these are really cornerstone for any type of nausea and vomiting. However, in pregnancy, they've kind of taken a backseat due to some literature within the last 5 years or so that's been published, and I'll talk about some of these down on the next slide. I think I've got a bullet point on it. There's 4 products available. There's pretty much one that's always used, though, and that's called ondansetron or Zofran. It comes as generic tablets, and orally dissolving tablets. Also can be given IV or IM, so you can give it multiple different ways. It's kind of expensive, but it works fairly well. And then there's the big controversy with pregnancy risk. So there's been a number of studies published with, I think, pretty conflicting data, and a lot of the studies, I don't think A, were all that well designed, or B, are showing results that are really all that profound. So some studies have shown, looking at basically data mining into large pools of data from European countries where they have public health services where they can look at pregnancy exposures to drugs, and then they can cross-reference that with child and birth defects. And there have been some very small correlations with increases in cardiovascular birth defects and cleft palate in 2 separate studies. There have been other studies that have done similar things that have found no risk. So because of this, people have been a little bit more apprehensive about Zofran. Zofran used to be first line for pregnancy until these studies have come out to show that it's a little bit more convoluted. And I would really encourage you, specifically since this works in your practice, to do some research on your own if you want to look into this more. You could hear it from me and my opinion, which I've given you, but look at the studies on your own because they're widely published, and I would just go to PubMed and do a search on ondansetron and pregnancy, and you'll probably get some decent hits. I think it'd be well worth your time, especially since this is going to be within your wheelhouse. It's something you're going to want to know. You'll learn it a lot better if you go through those studies on your own than if I walk you through them. The other medications, I'm not going to touch base on any of them. I won't test you on any of the other 3. They're mostly variances that are used in chemotherapy, but not really anywhere else. So we'll ignore that for now. These medications, Zofran, very well tolerated for the most part. Mild headaches are the most common side effect, and it can prolong QTC interval, which if you give a lot of it over a long period of time, or you combine it with another drug that also prolongs QTC interval, you can end up with a compounded problem, but usually it's fine if you're just giving it as needed. You don't really have to monitor. Steroids is something you can try. Basically, most of the data is from chemotherapy, highly emetogenic chemotherapy regimens, but you could potentially use it in other people. Steroids do have some role or some safety issues in pregnancy, but generally they're thought to be, for the most part, safe to use. So you could try it in a pregnant patient, but for the most part, try some other options first. It can be like 4th line, 5th line. And cannabinoids, I just got this slide on here for reference. I'm not going to test you on this or talk about it, but mostly chemotherapy or severely refractory nausea and vomiting. And I don't have anything on here about medical marijuana, which could be an indication for that as well. But the odds of seeing a patient actually on it for that's not undergoing chemotherapy would be really, really odd. Usually it's chemotherapy related or some sort of severe chronic end-stage disease related thing. Benzodiazepines could be given too. I don't necessarily recommend giving them to a pregnant person regularly, but you could try it. The one thing I would say is that if you have somebody who's having a lot of nausea and vomiting and they're having a big anxiety component associated with it, a drug like lorazepam could be helpful because it's going to help with the anxiety. It's also going to help with the nausea too. And it's a class that's on its own. We'll talk about benzos more during psych. But when you look at Ativan, think about it, kind of keep it in the back of your head again. Anxiety plus some sort of nausea could be a good tool to think about using. So some other considerations of pregnancy, dietary triggers is going to be an important thing to watch out for. So avoid empty or overly full stomach, treat heartburn. We're going to talk about heartburn here in the next slide set. And cold, clear, carbonated, sour fluids like lemonade or something like that. Small amounts, 30 minutes before after meals can help a little bit. Ginger foods and supplements have been shown to be effective in some trials. There's a number of different ways to consume ginger, teas, raw ginger, supplements of ginger, ginger aromatherapy, stuff like that has all been tried and shown to be reasonably effective, and it's reasonably benign. It's not really going to hurt anyone to try it. I didn't mention pyridoxine or doxalamine because there's not really much to talk about. Vitamin B plus doxalamine, which is an antihistamine, sort of anticholinergic over-the-counter medication that's mostly used for sleep. It is actually shown as category A, which is one of the only medications that I know of that's category A. There aren't many of them out there. The evidence for it's pretty unimpressive, I think. It's very mild. However, it's essentially not going to hurt anyone to try it, so you might as well give them the opportunity to explore it on their own. I will very strongly say not to prescribe Diclegis, which is the brand name product, because it's ridiculously expensive and you can buy both components over the counter cheaply. So tell them to buy over-the-counter doxalamine, over-the-counter vitamin B6, and don't prescribe Diclegis, please, because you're going to make your patient pay a lot of money for something they could buy really cheaply over the counter. So generally speaking, how would you treat somebody? Usually pyridoxine doxalamine would be choice 1. After that, you're looking at maybe a different antihistamine. You could try diphenhydramine, metoclopramide, and then ondansetron would kind of be how I would approach it. So those 4 things in that row. And then I've got another little bit of a summary here, which we kind of already covered. And we'll talk about acid suppression now, which is another cornerstone, I think, specifically for pregnant patients who can have a lot of heartburn. It can go hand in hand with nausea, and it can go hand in hand with any person when it comes to nausea. So you've got a lot of acid-secreting parietal cells in the stomach, and so the idea is to suppress that. And you can do it by working against acetylcholine, which we don't really do, but we're going to focus on histamine receptors, and you can also just inhibit the actual pump, the end-stage process that's excreting hydrogen ions directly. I'm going to skip that slide and talk about this one because it's easier to understand, I think. So basically, if you think about this is your stomach, this is your parietal cell, and there's a bunch of these lining the stomach. You've got your proton pump, or PP here, and you're going to be releasing hydrogen ion in the form of hydrochloric acid to get that pH super low. So your stomach's really an acidic environment. To suppress that, you can do a number of things. So histamine is going to be kind of a cornerstone here. If you block these receptors, you can block part of the process. However, gastrin and acetylcholine can still stimulate your proton pumps indirectly as well. So you don't block the whole process. Now, if you block the proton pump itself, that's the last stop. And so there's nothing else that can interfere with that, which is why histamine 2 blockers, while effective, are not quite as effective as proton pump inhibitors. So histamine 2 has been the cornerstone of treatment and was the old mechanism of action. And PPIs are newer therapy, although they've been around 10, 15 years now. And they're quite effective for a lot of different stomach acid-related indications. There's a few differences I'm going to point out here, though. So let's talk about PPIs first. Being the most potent inhibitors of gastric acid. You want to take them on an empty stomach. So usually people take them before breakfast. That's because they work best when the ATPase is activated. So the idea is you take it before breakfast. It has to absorb into systemic circulation. It's not working locally in the stomach. So it has to get through, absorb, and then you eat your meal 30 minutes later. By the time that drug's fully absorbed, your proton pumps are nice and active. Those ATPases shooting out hydrogen ions are running rapidly, and then you can use your drug to go and find those activated proton pumps, and it's going to inhibit them. Most people use it once a day. It inhibits about 66% of acid output after 5 days. And the reason it's 66% is it's very difficult to inhibit and stop every single parietal cell. It's impossible. So you're going to get some production. But if you inhibit a lot of that, you can really increase the pH of the stomach pretty quickly. So 5 days of therapy usually to build up to full use. You usually get some impact after a single dose, but you really need to take it for almost a week to really get full effects. As needed usage is not reliable for that reason. And because it needs to be taken on an empty stomach, again, you have to plan a little bit with this medication. As needed use doesn't work as well. The effects usually continue about 2 days after discontinuation. So if you miss a day, you're still going to be covered, which is nice for most patients. All these medications are pretty much the same, and usually you're just going to decide one based on cost. Several are over the counter now, so Prilosec, Nexium, and Prevacid are all over the counter, so people can buy these themselves without consulting a physician, which is their choice, but there's some issues with that, and we'll talk about side effects here. There's no different clinical difference within clinical trials. None of the differences reported are statistical or clinically important. Some dose starting. So if you're looking at dosage, here you go. Occasionally we get people who they're on one and then insurance wants them to be on another, so you have to dose adjust a little bit. And to know some conversions is good in practice. I'm not going to test you on it though. And so here are all the drugs broken out a little bit more. Omeprazole is probably the oldest one, and it was OTC for several years prior. If you actually read a box of Prilosec OTC, you'll see that it says not to use more than 14 days, which is kind of interesting because a lot of people take these medications basically for life. Nexium and pantoprazole both come IV, which can be helpful for GI bleeding and acute things, which we don't really care about in this class. And then you have a couple other ones. Acifex is probably the only one I would say not to prescribe, just because it's usually more expensive than everything else. However, it did recently go generic, so that cost should come down. The other one is Dexilant or dexlansoprazole, which is supposed to have a biphasic release. It's the newest product. It's also brand name prescription only, and I would also probably say not to prescribe it. If you do prescribe that, what the insurance company is going to do is tell you to prescribe something else anyway, so hopefully by listening to me, I'm saving you a step if you decide to prescribe that in the future. Drug interactions, PPIs are CYP metabolized, so they can compete for that metabolic pathway. And out of all of them, pantoprazole is thought to have the lowest risk of this. There was, but most people think that it's not a clinically relevant interaction. There's this big thing in the past where people who were taking Plavix or clopidogrel, which is a platelet inhibition agent everyone takes after they've had a heart attack, were that Plavix is a prodrug, so it needs to go through the CYP system to be activated into its final form. So this drug was interfering, these drugs in general were interfering with Plavix's ability to get metabolized into its active form, and in that case it ended up, people were really worried that this life-saving potential medication wasn't being effective. There's a big trial that came out that showed it wasn't really a clinically relevant issue, so basically no one cares about it anymore. However, I'll just put it out there that there was this big thing about drug side effects, and then the other thing to think about is that acid suppression in general can affect drug absorption. So if you have somebody on medications, you just might want to check the drug monographs and make sure that they don't need to take it, or that the acidity of the stomach isn't going to be a big deal for absorption. Generally, these medications are over the counter, so they're probably quite safe, right? For the most part, yes. However, the one thing to think about is that you're decreasing one of your body's first-line defenses against enteric infection. And while in our country and in most developed worlds, our food supply and water supply is safe enough where we're not really exposed to many enteric pathogens on a regular basis, the rest of the world might not be so lucky. And it's just something to think about, that if your patient is on one of these medications regularly and they do go abroad, they might be at higher risk for an enteric infection. There's also actually pretty good correlation between PPI use and C. diff in any country. And it doesn't have to involve antibiotic use either, which is kind of interesting. So people are at risk regardless of whether they've had antibiotic exposure. And it is much higher compared to H2 blockers. And there's some other things on here. Pneumonia, malabsorption. Pneumonia is kind of a lower priority. We don't really have as big of associations with that. Malabsorption of vitamins can happen too. There's been some associations with high gastric or high gastrin levels being associated with stomach tumors in rats. However, we haven't seen this crossover into humans, so likely not significant. But because you're suppressing the proton pump, your body does upregulate gastrin production, so there is some concern that that might be associated with certain types of cancers. Okay, so H2 blockers, why would we use these when we have PPIs? Well, they work a lot faster. You can take them as needed. You don't have to take them on an empty stomach. So if you want somebody, so if you have somebody who just is periodically gets heartburn, it's not something they get consistently and regularly, this is the drug to put them on and have them use it as needed. You're going to decrease their risk of some of those enteric infections, and it's going to work faster and better for them. You can't take a PPI at 6 o'clock at night after you've had a meal. It might not work all that well. But you can take an H2 blocker then, and it likely will work. So that's the big advantage, I think, with these medications. They're also cheaper, I think, generally when you're buying them over the counter. Side effects are minimal overall. They have some similar risks to PPIs, but mostly the studies haven't shown them to be as problematic, and there's way less drug interactions with these to consider too. So these are the three drugs: famotidine, ranitidine, and cimetidine. If you're wondering about pregnancy, this ranitidine is the drug of choice. It's the one that's best studied in pregnancy. Famotidine is likely fine too. However, ranitidine just has more data associated with it. Twice daily dosing. No clinical difference between one. We don't really use cimetidine anymore. It's like a 3 or 4 times a day, and it's got some more drug interactions. It's kind of can be problematic too with the elderly as well. It can have some central nervous system related side effects. Antacids can always be used if you want. They're going to neutralize acid on contact temporarily. Tums, Rolaids, Gaviscon, etc. can all be used. Sulphonylfate is a polysaccharide that binds to injured gastric tissue. So basically, if you have an ulcer, it can cover that up. It's really only used for that, although it is effective in pregnancy, so you might see it as an alternative prescribed in pregnant patients. If somebody wants to take something that's not going to be systemically absorbed at all, there's no risk or side effect. You do have to take it 4 times a day, though. Bismuth, Pepto Bismol suppresses H. pylori activity, so if you have a gastric ulcer related to that, it could be effective for that specific indication. Okay, just to talk about GERD really quick. So with chronic heartburn, you want to treat based on severity of symptoms and how long the person and how frequently the person's getting it. Lifestyle, diet, so weight loss, elevate the head of the bed at night to help gravity work with us. Avoid triggers. Tight-fitting garments can potentially contribute. Chewing gum or lozenges regularly can promote salivation, which can help with preventing GERD, and tobacco and alcohol can trigger GERD as well. So just avoiding triggers and trying some weight loss, elevated head of the bed, etc. So if somebody has GERD, how do we treat it? Well, if it's mild to moderate, which is less than 2 episodes per week, you're going to be given a low-dose standard H2 blocker. If you get persistent symptoms, switch to a PPI for 8 weeks once controlled. And if somebody is right off the bat, either has some erosive problems or they have more than 2 episodes a week, so you basically, if you're not mild to moderate, if you're more severe to start with, you're going to go down to here. You're going to start with a proton pump inhibitor twice a day. I do see people on BID PPIs occasionally. There's not really a good indication for this unless you have an ulcer or some sort of really severe episode, but I see people take them a lot twice a day. It's not always appropriate, I don't think. And pregnant, sulphonylfate, ranitidine. Proton pump inhibitors have been used in pregnancy and can be used in pregnancy, but they're reserved. So you'd always start somebody on ranitidine. Try that first. If they aren't getting good effect, try your PPI. And then peptic ulcer disease. You want to make sure you're getting tested for H. pylori and doing an appropriate antibiotic course if necessary. Then just watch with your PPI therapy. You are going to suppress acid for peptic ulcer disease. The GI tract can heal a lot better in a more high pH environment. And rebound acid hypersecretion is something to be considerate of. So if somebody is on high-dose proton pump inhibitors, or even if somebody doesn't have peptic ulcer disease, let's say you had a pregnant patient who had terrible heartburn and was on twice daily PPIs. After pregnancy, she's like, hey, I'm probably going to be fine now. She stops taking it. She could get really severe rebound acid secretion after having that high dose for quite a while. So try and taper. So if they're on twice daily, taper them down to once daily for a month, and then maybe taper them off. If they're on once daily, you might have them go every other day for a little bit just to make sure. You could trial them off cold turkey and see, but just know that they might get some rebound issues. If somebody's on a regular dose of aspirin or NSAID, reduce the risk of GI bleeding goes way up, especially if you're older, but in most patients it's going to go up. So prophylactic therapy with proton pump inhibitors, H2 blockers is always going to be indicated for these patients. So if you have a patient who's taking it for rheumatoid or osteoarthritis regularly, just remember that this is a requirement if they're taking regular NSAIDs to be on a proton pump inhibitor. Combination therapy, can you mix and match most of these? Yes, you can. So antacids work great for quick relief. In addition to some of the longer acting medications. So you could give like an antacid plus an H2 blocker at the same time. PPIs and H2 blockers can be used together, but remember, you don't want to block your acid suppressing ability before you give a PPI. So PPI would be ideally done in the morning, and then people could take an H2 blocker in the evening if they're getting more acid secretion at night. That's usually the most common way I see them combined. For the most part, though, it's inappropriate to stack these up. Most people, if they're having that much reflux, there's probably something else they need to be addressed. So maybe a GI consult referral or a follow-up question from you at the very least. If ever I see people on a PPI and an H2 blocker, I always ask them why they're taking both. You'd be surprised how many people get prescribed something in the hospital. It just stays on their medication list. They keep taking it. They don't really know why. So it's something to consider. All right, that's all I've got for you. If you have questions about this lecture, as always, feel free to email me or discuss it on the class forum. Thanks, bye.